Good morning. First of all, I would like to thank President and the Council members of District General Hospital, Nawalapitiya Clinical Society for inviting me to do this lecture on rickettsial infection. And at the same time, I would like to thank the President and the Council members of Ceylon College of Physicians for accepting our invitation to have this kind of joint meeting with our Clinical Society. Indeed, it is a great pleasure and great honor to be with you all because we know Ceylon College of Physicians is the leading academic college in our country. So, thank you very much once again for you all accepting our invitation to have this meeting. And my topic would be rickettsial infection in Sri Lanka. And actually, you would understand why I have selected this topic in my lecture. So during my lecture, I will be talking on these topics: introduction, epidemiology and geographical distribution in Sri Lanka, clinical presentation and complication, and then of course diagnosis, clinical management. And also, I will be touching on rickettsial infection and pregnancy. As you know, now infectious diseases are one of the leading causes of morbidities and mortality globally. So similarly, we as Sri Lanka are facing few infectious diseases right now, especially leptospirosis, dengue, and also not forgetting our COVID-19, which is one of the highly contagious infection caused by virus. At the moment, we are facing pandemic of COVID-19. So with that, as you know, rickettsial infection or rickettsioses are a group of vector-borne diseases transmitted by various vectors, and it's a zoonotic disease. And human beings are accidental hosts. Actually, we are not the reservoir. We are basically accidental hosts, and there are some animals like rodents and also some mammals. They are the reservoirs. And when it comes to classification, there are various classifications. Actually, I will not touch on that, but basically there are two important genera: Rickettsial and Orientia, so which is related to our clinical setting. They are actually intracellular gram-negative bacteria-like organisms, and of course they are most of them are non-pathogenic for human beings, but sometimes when they accidentally infect human beings, they can cause various infections, febrile illness with various skin manifestation. Now, this slide, you can see the organisms within human cells, right? Now, this slide is very important. Actually, I have even three disease entities, especially three diseases which are related to us: typhus group, spotted fever group, and scrub typhus. Again, now when it comes to typhus group, actually all these cases are found in our country. You will understand during my lecture. I will go through the literature as well. When it comes to typhus group, Rickettsial proboscis causes epidemic typhus, and it is transmitted by pediculus human, that is human louse, and then Rickettsial typhi epidemic or mural typhus, and it is transmitted by a flea called Synopsia cheopis, and then of course spotted fever group. There are two important organisms: Rickettsiae and Rickettsial conuri. Rickettsiae causes Rocky Mountain spotted fever, and also Rickettsial conuri causes Mediterranean spotted fever group, and they are transmitted by a tick called tick of the family of Ixodoideae. And actually, the distribution globally, this typhus group is found globally. When it comes to spotted fever group, mainly they are found in US, and especially Central and South American regions, and Southern Europe, Africa, and some Middle East countries, as well as Central Asia. When it comes to scrub typhus, as you all know, Orientia is the causative organism, and it is transmitted by a larva or jigger stage of mite called Leptothrombedium. And also it is found in Asia, Northern Australia, Pacific region, and some New Guinea region as well. The important thing in this slide, these three categories of cases are found in our country, so I will go through the literature with my presentation. Now, regarding epidemiology and geographical distribution in Sri Lanka, now we are fortunate to have very good literature on this subject. Actually, thankful to our researchers, they have done a lot of research on this subject, especially University of Peradeniya, some researchers in Faculty of Medicine, University of Peradeniya. So I will go through those literature as well. Now, regarding earlier literature, there are reports of outbreak of scrub typhus among allied soldiers stationed in Ceylon during the World War in 1930s. Actually, there has been some case reports, and the first reported case in 1938 by Sri Lanka described two patients with fever for 2 weeks and skin rash from Norway confirmed having tropical typhus, that is Muran typhus. That is the first two cases reported formally, and but before that there have been so many cases in soldiers. And later on, in a study done by some researchers which conducted in 1972, there is a zero positivity of antibodies against scab typhus detected by indirect immunofluorescence assay was found to be 6% among hospitalized patients, medical students, blood donors. So at that time, they have concluded that it was not a major public health concern. Then the occurrence of spotted fever group, which I described earlier, because in Sri Lanka was first reported in 1994 by Dr. Rajaratnam and his team. So that is the first case of spotted fever. And in the same year, Dr. Vasantha Thilakarathne and Dr. Denai have reported a series of cases of Mura typhus from PH Peradeniya, where diagnosis was made as endemic typhus by wheat Felix test in 1994. Actually, nowadays we don't go by wheat Felix, but basically we are doing indirect immunofluorescence assay. However, there was one landmark study, that is one of the important study done on rickettsial infection by a research group led by Professor Gunaratne, which was published in 2003 regarding emerging rickettsial infection in Sri Lanka. The pattern in the central from this is one of the landmark study, I would say, because they have tried to identify the geographical distribution as well as the pattern of infection in our country. So after the study, they have described the geographical distribution of rickettsioses in Sri Lanka is varied and possibly associated with the distribution of vectors and reservoirs of animals. Now, according to this study, the central province has reported the predominance of spotted fever group rickettsioses because they have analyzed the sera and they have found out that spotted fever is the predominant type in central area. And regarding the distribution, that is where we are involved actually. Distribution of the spotted fever rickettsioses in Sri Lanka central province was mainly found in western slope of the hill, central hills such as Kegol, Mavanal and other part of the province up to Nawalapitiya. So that is where we are actually involved. Actually, we do see cases of rickettsial infection throughout the year. During last 3.5 years, I have managed probably more than 100 cases of rickettsial infection. Majority were, of course, having clinical features of spotted fever group. And again, in this study, they have concluded Mavanal, Kekor, Kampala, Nawalapitiya hospital, as well as the major tertiary care center for the East area teaching hospital, Peradeniya has a regular influx of patients with rickettsial. Serological evidence of scab typhus and Muran typhus has also been recorded to a lower extent. So predominantly is spotted fever group in central hilly area. Then another study, actually this slide, I think you can appreciate here. Now they have analyzed this slide I took from the same study. Now you can see majority of cases were spotted fever group 35, and then orange schistosomiasis, and then also rickettsial type. So predominant type was the spotted fever group. And then again another study done by basically same team led by Professor Gunaratne and his team. This was published after 10 years of first study. Again, it is one of the important studies because it is the central hills of Sri Lanka. Serological evidence of increasing burden of spotted fever group. This is basically the same type of study, and they have proved that again predominance of spotted fever group in this area, but the burden of disease has increased dramatically over the last 10 years. Now, in this study, all patients with clinically diagnosed rickettsial infection admitted to Professor Medical Unit of PH Peradeniya during the period of January 2002 to December 2007 were included in the study. Quite significant number of patients, 371 patients, fulfilled the above criteria. Now, You can see here, first graph shows the number of cases in each year, and the second one shows actually the distribution throughout the year. Now, you can see almost similar cases throughout the year, so that is one of the important conclusions they have found. All patients presented as sporadic cases throughout the year without any seasonal variation. That is one conclusion. And patients were residents of the central province of Sri Lanka, living along a stretch of lands with hills and valleys of approximately 50 kilometers located between Nawalapitiya in the north, Kegol in the south or western slope. Similar, this study again confirmed previous study findings and same pattern of distribution because now as they have described in the previous study, the area varies from semi-urban to rural, where lush of high-growing evergreen vegetation is the human race. Actually, this area, most of these areas like rural or semi-urban, and majority of cases were either farmer or they were having low socioeconomic status, either estate sector or vegetable farmers or paddy farmers. Now, in this study, majority of cases had positive ID for Rickettsial economy, suggesting predominance of spotted fever group rickettsioses in the rural setting. In contrast, scrub typhus occurred at a lower rate in the region and murine was detected rarely. Again, this confirms previous study. If you go through the number of cases, majority was spotted fever group, then of course scrub typhus, and then the lowest was murine typhus. Now, this slide shows you some data about our Kandy district and Nawalapitiya MOH division. This was partly orally actually. Now, in 2018, there were 86 cases in Kandy district. 2019, 96, and 2020 up to now 71 cases. When it comes to our MOH division, we had 42 cases in 2017, then 45, 44 like that. But if you compare with the Kandy district in 2019, almost half of the cases were reported from our area. So that gives some idea that we are seeing a quite number of cases with rickettsial infection. Now, what about other provinces? Actually, now I'm going through this literature to understand that because this is again a study done by Professor Untitled Chapter and his group from University of California. Now, rickettsial infection and their clinical presentation in the Western province of Sri Lanka, a hospital-based study. So we'll see what is happening with that study, right? Now, again, this study was carried out during 12-month period from November 2002 to October 2003, a prospective study done on patients who were admitted to the Professorate Medical Unit, Colombo North Teaching Hospital, Ragama, Sri Lanka, with fever of more than 5 days duration and clinical suspicion of rickettsial infection. Number of cases were 31. Actually, they were presented as sporadic cases and were living in roughly about 10 kilometers away from within that area of the hospital. And out of that, 69 were living in urban area, 31 were living in semi-urban. So you can see now not only rural, but there are urban cases as well according to their study. And the other important finding according to their study, Orientia Shushkumasi was the leading cases that they have found 66% causing scrub typhus fever, and the spotted fever group was less in number, that is 28. So in Western, when it comes to Western province, majority were actually, according to this study, Orientia, that means scrub typhus cases. Now, what happens in North, in other parts like northern province? This is a very good study done by Dr. Pradeepan and his team, and published in 2014. Actually, they have analyzed 64 cases of suspected typhus cases from 2012 to 2013 in northern part, and of course, out of that, it was found that 84.4% of the patients presenting with clinical features of rickettsioses. That means very quite a high number. Out of 64, 54 cases were scrub typhus, and they were positive for scrub typhus with a significant majority of time typical HCA. That is one of the important findings. So 90% of them were having HCA. So if you get a patient with fever with typical HCA, so we can arrive at a diagnosis without any hesitation that because they were having 90% of cases that HCA was there. This is one of the important study which was done in another part. So what about other other areas like southern province? Now, according to the available data up to now, what they say, they have a mixture of infection actually. So it varies like spotted fever, and then of course some staph typhus cases, neuron typhus cases like that. So basically, southern part has a mixture of infection. So what about other areas like northwestern province? According to the available data, at the moment it is again predominantly a staph typhus group. And north central province, as you all know, actually now we have some data. They have found the majority of cases were like staph typhus again. So this gives some idea about the pattern of cases in our country. Majority, the northern part, typhus, and then north central, and northwestern, western province, all were actual typhus. Whereas central Giri area it was the predominant type. Now, this is one of the important study again done by two researchers from University of Peradeniya. Now, in this study, they have tried to find out epidemiology of rickettsioses in Sri Lanka. This study was published in 2014. Now, what they have done actually, they have analyzed 615 samples received from 23 hospitals representing 8 provinces were tested using ELISA indirect event of reference method to find out what is the pattern of cases found in Sri Lanka. Now that is again confirmed previous studies finding. I don't know whether you can appreciate now this map I took from their study. Now you can see this yellow stars represent spotted fever group. So you can see central hilly areas as well as Uva province. That is actually they have taken sample from Bandulla, Monaragala as well as Pietala. All the majority was spotted fever group, whereas north central province and northwestern province, and of course they have taken sample from Trincomalee as well. They have of course like typhus group, whereas the southern part again you can see mixture of infection. You can see one yellow star as well as one orange star. And the other interesting thing in Sabaragaon province, they have found basically again it's scrub typhus. So this gives very nice idea about our pattern of distribution in Sri Lanka. Now, if I were to add the previous study done by Dr. Pradeepan, so it is almost northern part represent northern part. So again, it is typhus. Scrub typhus group is the predominant type. Regarding clinical presentation, as you all know, now it's like similar to most of the infection, they can present with fever, arthralgia, myalgia, headaches, and other symptoms. And also, very important thing is the cutaneous manifestation. I will go through again with literature and regional lymphadenopathy, organomegaly, and then manifestation related to complication. Now, what about fever? Now, regarding this is one of the common symptoms that they can get. Actually, the type of or the pattern of fever, we don't get any data. I tried to find out whether they have done any research on this aspect, but actually none of them have concentrated on this the pattern of fever. Now, this I have taken from internet, but actually this gives you some idea about type of fever. It's called remittent fever, where fluctuation within 1 Celsius, but it does not touch the baseline. This is seen in most of the cases of typhus group, right? Even in my experience, now I have seen very few cases of typhus, but they have remittent type of fever where fever does not come to the baseline. So, what about spotted fever group? Actually, they get what you call intermittent, where fever comes and touches the baseline and then again goes up. So, in my experience, last 3.5 years, I have seen most of the cases they were having intermittent fever. Now, our SHOs and my junior doctors, they know when you get a patient with fever more than 7 days, intermittent fever, if we can't find out any other reason, so we tend to start doxycycline. They respond by next day when they are quite well, so we know it's almost diagnostic. Right? Now this slide I took from the study done by Dr. Guratnani's team about symptomatology. Now this is important thing because you can see majority of them were having fever, and in the skin manifestation where they are more than 71% of cases, and in that study they have found one important skin manifestation called fern leaf skin necrosis. So they were seen in some of the cases, and also some rare cases, presentation like tinnitus and deafness and some neurological manifestation like confusion, hallucination, and so on. Those are some of the uncommon presentation of spotted fever flu cases. Now, regarding cutaneous manifestations, that's again very important. And sometimes, if you see a case with typical skin rash, you may arrive at a diagnosis without any doubt. Now, there are various skin manifestations have been reported by our research groups, and in studies conducted in Sri Lanka, what they have found, Eshka has been mostly associated with scrub typhus, and but actually some studies they say it's 90% according to previous study, but some say 25. There's a huge variation, but in my experience also majority of them have HK when it comes to scrub typhus. Now this is a typical HK. You can see. I think you have seen this. Epimatus H and central scabbing, scab formation and some erythema around it. Now, when it comes to spotted fever group, what they say they are presenting with fever and rash. Actually, proportion of patients with spotted fever group presenting with rash has been varied from 16 to 100. But again, it's a big variation according to data. SCA is very rarely seen in this group. So, what are the skin manifestations of spotted fever group? Rickettsial infection in central province of Sri Lanka, a descriptive study. This is again very good study done by same sort of team from University of Peradeniya. Now they have published this one in 2014 again. Because most of the studies done by Professor Murat's team, because cases were abundant in this area. Now this is a fairly good study. Actually, it was carried out from November 2009 to October 2011. They have confirmed the cases with direct immunofluorescence assay using IgG and IgA. Out of 210 clinical cases, 130 had cutoff antibody, either for rickettsial infection. All these 134 cases had fever, skin rash, and of them, 98 had discrete maculopapular rash, while had 8, that means 6% had burn-like skin necrosis, which is very characteristic. And again, 6% had heel tick bite mark. And also they have tried to analyze the skin rash more details about the average size. It was 5 millimeter in average skin size, rash size, and then up to the percentage of the body involvement. They have found 52% of the body surface could be affected due to this rash. Now, other thing, these cases can be presented with joint symptoms like mimicking arthritis, swelling and ankle joints, and as well as feet, and it can extend up to knee joint. Right? Now, this slides again now gives you some idea about the distribution of the lesions. Right? You can see arms and forearm in 81% of cases, legs were involved in 67, toes were affected in 56, and palms were affected in 55. This is very characteristic when it comes to spotted fever group, because majority of them have palm, soles, as well as forearm involvement. So more than half of them will have this sort of distribution pattern. And the type of skin involvement, again now they have described majority of them, that is 98% of them were having maculopapular rash, which is very characteristic, very discrete. I will show you some slides. And then of course very rarely maculopapular. Another important burn leaf skin necrosis is less common, 6%. But very characteristic again, and the rash were most of them were erythematous in nature. And as I described earlier, size of the lesion 5 millimeter, and the extent of distribution again 52%, which is very big area. Now 3 images. Now first image A, you can see fairly old tick bite. Image B, you can see a scarred tick bite. Actually, this is not a typical scar, but the scarred fairly old one. Image C, you can see a fairly new, tick bite mark. Now, this is what is I described earlier, fern leaf skin necrosis. You can see this on my left side, whatever the first image shows. The skin, you can see dark, skin necrotic areas over the shields. This is very characteristic for spotted fever group. If you see this sort of lesion, Actually, it is almost diagnostic. The problem, these patients, they get other image you can see the typical maculopapular rash involving palms and then forearms and shins as well as feet. Usually, this maculopapular rash will appear after 2 to 4 days of fever. By fifth day, it will disappear. So, if patient is admitted, say after 7 days with fever, you may not see this maculopapular rash. Whereas burn leaf skin necrosis would would appear after 7 days or so because they are. It's like immune mediated vasculitic lesion. So and they will be persistent for weeks sometimes. Actually, I have seen fairly significant number of cases. They were having joint symptoms and this necrosis for weeks. Now, this is again a case of spotted fever, similar burn leaf lesions, and this one shows typical skin rash involving palms and soles. Now, this you can appreciate the joint involvement where you can see the swelling of ankle joints as well as feet, and then the scrotal involvement is again in both cases from spotted fever group. Sorry. Now, this is again same sort of vascular regulation. You can see over these big toes and even also affected. Now, if you see a case with fever, ongoing fever with these lesions, you may arrive at a diagnosis with the appropriate clinical setting, right? What are the complications? Of course, they can develop various complications like neurological complications like encephalitis, meningoencephalitis, extrapyramidal involvement, mimicking even Parkinsonism. And of course, they can get cardiac involvement, not that common, but still they can get myocarditis, arrhythmias, and sometimes renal failure, multi-organ failure, sepsis, and even hepatitis B, which are very you all know. But regarding neurological manifestation, again, some studies done by Professor Guratna's team, they have described some cases of encephalitis and also even extravagant symptoms mimicking Parkinsonism. Actually, the important thing when they are treated, they completely improve with their symptoms. That is one of the important thing. And they have found EEG changes characteristic of encephalitis perceived in these patients, and majority were elderly. And of course, they have described some isolated facial necrosis following intraoral tick bite. Now, again, this is a case report recently published by a team led by Dr. Vasant. This case was, reported from teaching hospital Kandy, an atypical case of rickettsial spotted fever myocarditis mimicking Wales disease. This was published in July 2009. A very recent case report I found out when I searched for literature. This is a case, 65-year-old male who was admitted with Kandy with fever, low BP, and and features of sepsis. And he was fighting, he was ecteric, and they were managing like leptospirosis, but with treatment he was not improving. Then they have done indirect immunofluorescence assay, which confirmed that he was having spotted fever myocarditis because he had low ejection fraction and he was having heart failure. And with the treatment of doxycycline, he improved over a few days. Now, these are some of the rare presentations like acute hearing impairment due to stub typhus and unusual pancytopenia secondary to hemophagocytosis syndrome in Rickettsial. And major joint arthritis. Be alert about these atypical cases as well. Now, diagnosis is not that difficult. Now, relevant epidemiological factors, history of exposure to tick, flea, mite bite may be helpful, but it may not be in all the cases. Presence of characteristic skin lesion, which I described earlier, with the distribution of lesion. If you see a patient with characteristic skin lesion in the characteristic distribution pattern, so you may arrive at the diagnosis. Other thing is the pattern of which I described earlier. Another important thing is the dramatic response to appropriate antibiotic. That means if you start doxycycline on clinical ground, they respond very quickly. Usually by second day fever comes to baseline. That is very pathognomonic for these cases. Other thing, supporting evidence for that kind may be normal, but they can have leukopenia, thrombocytopenia, anemia, and elevated CRP and other inflammatory markers, sometimes hypoalbuminia, hyponatremia. They are not specific, but important thing is the clinical diagnosis and starting treatment. Now, this is again I described. So, once you start treatment, of course, by 48 hours, actually they are well. So they will be fine. So they will have fever, they will not have fever. Clinically, they will improve. So therefore, it is almost again supportive of the diagnosis. Now, how do you diagnose? This is the most accepted method, indirect immunofluorescence antibody based assay. Actually, it has very high sensitivity as well as specificity. When it comes to diagnosis of Rickettsial, but actual species identity is not that easy. According to CDC recommendation, if you were to diagnose acute rickettsial infection, if you do indirect immunofluorescence assay, if the theta is 1 over 128, it is diagnostic. But can we apply that to our Sri Lankan setting now? According to Professor Ranjan Premanathna, what he says, since we have high, baseline serum antibody titer, we can't apply this cutoff value for Sri Lankan cases, so we have to have higher values. After analyzing 470 samples by November 2010 in his laboratory, he concluded that indirect immunofluorescence as a IgG-based diagnosis of Rickettsial in the endemic system of Sri Lanka, when the serum sample is obtained more than 7 days of in a single. So if you were to diagnose after 7 days, you have to have a titer of 1 over 256. It is diagnostic for all subtypes. Cases and 90% of spotted fever. So if the level is less than that, you have to repeat sample after 2 weeks to show that there's a rising titer. So therefore, our values are fairly high for the diagnosis. Now you can do cutaneous biopsy obtained from the skin lesion, and if the genetic materials are there, you can extract and PCR amplification can be done. In fact, it has been done in our research groups, and they have found out even species identification has been done. And then what about PCR amplification from peripheral blood? What they say is very low sensitivity, therefore normally we don't do, but of course lesion, biopsy taken from the lesions and PCR amplification can be done. It has been done previously also. Now, regarding treatment, you all know it is very straightforward. You can use doxycycline, that is a drug of choice. There's no doubt. So they will respond within 48 hours. But there are other drugs like chlorphenicol, which has been used extensively in the past, and nowadays we don't use. But azithromycin has been used in the scrub typhus group. Actually, there's some evidence from other countries regarding the use of azithromycin in scrub typhus. Then, of course, management of complication according to the organ system involvement, and early diagnosis is important to prevent complication and start treatment on clinical ground without waiting for the laboratory investigation. That is very important. Now, what about pregnancy and infections? One of our chairperson is a biology. I think it may be helpful for him also. Now, we have been managing 3 cases during my period spotted fever group in this hospital, all completely improved with. Now, regarding literature, now I try to find out what is the drug. They say it is in spotted fever group. You have to use either chlorphenicol or doxycycline. But in case of scrub typhus, we can use azithromycin, but this single dose is enough. But in our case, I have given 3 days. 3 days, so they all 3 cases improved. Problem with chlorphenicol is the gray baby syndrome, as you know, in the latter part of pregnancy, and when the baby is born, they can get these problems and aplastic anemia and so on. But again, I searched for literature regarding use of doxycycline. Actually, I couldn't find our cases in Sri Lanka, but other countries like Central America, South America, a lot of cases are seen. But they say even in pregnancy you can use doxycycline if the cases are severe enough, because otherwise patient can have, mother can die of spotted fever typhus infection. Therefore, doxycycline can be used according to evidence-based approaches suggest that therapeutic doses of doxycycline don't pose a substantial risk of malformation or staining compared to other drugs like this. Therefore, we may consider giving a doxycycline, but again, you have to go by the cases. Now, I think I have come to the end of my presentation. Now, a few things I want to tell you. One thing, rickettsial infections are found in almost all parts in Sri Lanka. In the geographical restricted area, you would have understood in my presentation. Now, we see cases throughout the country. So, as clinicians, it's our duty as junior doctors to find out, diagnose these cases. Otherwise, they can have morbidities as well as mortality. Right? Need to consider in all patients who are admitted or seeking medical treatment with fever and rash in the appropriate epidemiological context. So, if you go back to the epidemiology, ask about the history, tick bites, flea bites, and so on. Especially area like this, if you get a fever and rash, you have to think of rickettsial infection. Treat early on clinical diagnosis to prevent complication. And according to the available data, spotted fever is the predominant type in central ED area, and then of course types in other areas. So those are the take-home messages. Thank you.